Can you still see me?
Yeah, I can see you.
All right, good.
Great, so that's us live. I'm just going to give it a couple of minutes so everyone can join, and then we can go ahead and start.
Yeah, no problem at all. Just a second, I'm just going to get my charger, just in case.
That's fine, no problem. Right, okay. So I think I'll go ahead and start just now. Are you okay with that, Baraa? Are you ready?
Yeah, I'm ready.
Yeah, great. Okay.
Can you hear me? All good? Everything? Yeah.
Yeah, that's grand. Right.
Yeah.
So thank you everyone for joining us today. Today is going to be the last session of the Mind the Bleep Urology series. So thanks for all joining us. Today, Dr. Baraa is going to give us a short and sweet series or session, basically, on some practical tips in urology for junior doctors and juniors in general. And hopefully you can all remember this in the days to come when you're working on the urology wards. So I'll go ahead and introduce you. Baraa, go ahead.
Hi, Zach. Thanks. Hello, everyone. Good evening. Thanks, Zach, and thanks, Mind the Bleep, for having me and giving me the chance to actually present to everyone here. My name is Baraa. I'm one of the Foundation E2 doctors, and I currently work in a hospital called Furness General Hospital, which is in the northwest of England. It is about a 40-minute drive to the Lake District. Very small hospital, really, in a very small town. So, yeah, all the resources that we have are sort of minimal, but yeah, I thought I would use this chance and actually talk to you guys about my experience in urology, this session is actually not going to be so informative, well, not so educational, but sort of more of my experience and things that you could sort of maybe hopefully use along your journey, whether you're doing urology or whether you're just coming across your surgical on-calls that might, cross-cover urology. Right. So basically, I'm just going to talk to you guys about my urology experience, talk to you guys about urology as a surgical career, things to look forward to during your urology placement, some practical tips that you can hopefully be useful and beneficial to you all. And then at the end, I'll talk to you guys about some urological emergencies just briefly, and then before we can crack on with the questions. Unfortunately, my consultant was supposed to be giving this talk with me, but he's off sick at the moment. So maybe, hopefully in the near future, we could possibly have a session where we can both talk to you guys about some our experience basically working in a small district hospital. Right. The reason why we all basically wanted to give you this talk is that urology in med school was basically just covered as a topic rather than a specialty. And it just really was brushed over in medical school. Initially, when you come across urology, when you start working, you might get this sort of daunting feeling and daunting experience, and it's normal because of the limited experience that you have. Urology actually is an expanding specialty, so it's normal for you to feel out of your depth initially, but hopefully that should improve throughout your rotation. One thing that I need to tell you guys is that urology is actually really, really fun. If you make the most out of it, you will actually enjoy, and you never know. That's the thing that I when I first joined is I wasn't quite sure and I wasn't sure of what to expect out of the rotation, but at the end of it, I actually have it managed to sort of convince me to do it as a career, really. So I have done urology when I was in F1. That was last year during sort of peak COVID, if you'd say. I was actually the only junior doctor on the team. I did have a CT1 doctor with me, but she sort of left in January because she had a lot of annual leave and study leave booked together. So as you can expect, I didn't have a lot of time in theatre, unfortunately. But what I did have is actually a lot of one-to-one teaching, which was consultant-led. I did have a lot of practice. And because you're the only junior doctor on the team, you do get quite a lot of bleeps, really. So the interesting thing is that we didn't have a urology ward, so all of our patients were actually outliers in the surgical wards, medical wards, and just scattered around the hospital. And towards the end, you actually do become everyone's favorite because you're the only one working there. What was also really beneficial for me is that we did have some sort of weekly departmental teaching sessions. And you do get that experience. I did manage to get some experience teaching regionally, locally to different sort of healthcare professions throughout. So I thought I would just give you a sort of a brief overview of what my day-to-day basis was in urology. So I would start urology, and my shift starts at about 8 to 8:15. But I would usually used to come early, 7:45 to about 8 and this is when I actually start going through all the patients, all the new patients that we have, making sure I know where all the patients are. I would also do my own mini round, making sure that I actually know and I can put a sort of a face to each of the names that I have on my list. From 8:15 until 11 a.m. This is basically when we used to go on ward rounds and we would go through the referrals. And this was actually a really valuable teaching time because every time we see a patient, we would actually stop for like 5 to 10 minutes and actually talk about the patient, talk about the management. The consultants were really great as they would actually give me the opportunity to sort of be involved with the management and be involved with decision making that otherwise a lot of people wouldn't be involved in. After that time, from 11 to about 12:30 p.m., I will be sort of just catching up on my documentation, doing ward jobs, including discharge summaries, making sure that everyone leaves the ward that leaves the hospital in time because we were short on beds sometimes. And then after that time, you would I would just go for my lunch and then second coffee break. And then from 11:15 to about 5 p.m. This is when I would be chasing bloods, chasing scans, doing random jobs such as cannulas, catheters, and all the other bleeps from all the other wards. If the wards were quiet, I would use this sort of chance to go on theatre and clinics. Otherwise, I would just sit there and actually work on my audit and my QI. I've actually had quite a few audits and QIs to work on during my urology, which is great, really. So obviously, this is not like a fixed sort of timeline of what I would do, but this is just roughly what I used to do. Pretty much, apart from your on calls, obviously you get thrown out here and there sometimes. So yeah. So urology as a surgical career, really basically what discriminates sort of urology from the rest of the others is basically because you do get the best of both worlds. You get that bit of medicine, a bit of surgery combined, which is what I love about urology, because too much surgery and too much medicine can be a bit overwhelming. So urology is that perfect mix, really, where you can do a bit of both. You would have relatively short ward rounds. Obviously, that depends on where you work. You do get a lot of hands-on experience and practice when it comes to actual theatre, when it comes to catheters, when it comes to sort of bladder washouts and the other procedures that we'll be involved in. You do also get a mix of a good mix, I would say, of short and long operations. Again, it depends on where you work. And as a consultant or as a registrar, it would actually mean that you would have actually a fairly good work-life balance, which is what is sort of the thing that people look forward to the most nowadays. I thought I would talk to you guys about things that you should look forward to and hopefully enjoy when you were doing urology. So obviously the surgical experience is there, but also the most important thing is actually the new skills that you would be able to acquire, such as the catheter insertion, handling cystoscopies, doing other procedures as bladder washouts, and etc. And the most important thing is that you can actually try and brag about them to your other F1s, other F2s, or fellow medical students, if anything. And in urology, what I've actually realized is that you do get that sort of instant feeling of satisfaction and reward as you treat patients, because you do have that sort of high turnover rate in urology. And urology is that one specialty where a simple procedure, inserting a catheter, could bring a lot of sort of relief to patients, and this is where you sort of get your satisfaction and reward from. And again, you do end up having the chance to work within a really, really big entity, whether it's the cancer patients or whether it's other decision making that you would do on a day-to-day basis. Right. Obviously, in urology, you will come across a lot of catheterization. So it is really important for you to sort of know how to do it properly. And for you to be able to do it properly, I thought I would sort of give you guys some sort of tips and tricks on how to do it. So good understanding of the anatomy is actually a key for you to be able to do it properly and smoothly. Making sure you have a good grasp of the penis, and you would want to lift it at about 45-degree angle to the supine body. This will allow you to straighten the urethra, and it will be sort of a more straightforward insertion. You would want to insert the catheter until you sort of feel that it can bounce off the prostate, and then once you feel that you want to lower it down until the penis is actually almost at the same level of the body. Sometimes what I've seen is that if you twist the catheter gently as soon as you insert it, it will between your index finger and thumb, it can actually help sometimes make it easier. Now you will definitely come across this whether you're doing urology or you're doing other sort of specialties. But the two common reasons for failing a male catheterization would be, number one, obviously the enlarged prostate. For you to be able to sort of roughly gauge whether it's the prostate that is not allowing you to insert the catheter or not, the way I think about it is, if you have an enlarged prostate, then you would be able to sort of advance roughly about half of the catheter into the urethra before it bounces back and stops going forward. What I would suggest is actually try and use a catheter with sort of a larger diameter. So these catheters are less likely to cause any false passages and are sort of sturdier to push. If you're unable to do that, then I would suggest using a Tiemann tip or coded tip catheter. And I would only suggest you doing that only when you get familiar and comfortable with these equipments. Initially, I would suggest going around, speaking to your seniors, speaking to your registrars if you're doing urology, and making sure that you do know what the differences are between both and how to use both. They're fairly straightforward, but there are some sort of tips and tricks that you would want to use in real life that would make it easier. So here, this is what we call a coded tip catheter. It's almost the same as the normal one, but as you can see here, there's that sort of elevated sort of tip, and this helps you with this helps around the prostate area where you can squeeze through, and it's quite rigid here. is squeezed through the prostate and it goes in smoother. Team tip catheter is almost the same, but here it's made up of a different material really, and it's quite smaller here. So this whole sort of shape allows you to sort of navigate through the prostate if it's an implant one. The second reason is the urethral stricture. So the difference between a urethral stricture and a prostate enlargement is in a urethral stricture, you will only be able to sort of advance a little way into the urethra before the catheter will stop advancing forward. So what I would suggest is actually using a different type of catheter, which is a silicone catheter, and try and use a smaller one because the stricture might be quite small. As you can see here, this is what I mean by a stricture here. So if you have a smaller sort of catheter, you might be able to navigate through. But the most important thing is you would want to not try too many times. And if you can get it in, then my advice is to call a senior for some help, because they would sort of then opt for a flexible cystoscopy guided insertion, or what we call a urethral dilatation, or the other option is a super big catheter, which I'll talk to you guys through about later. Right, lubricant gel. This is going to be one of your sort of best friends when you work in urology. It is very important. You need to sort of use it before any catheterization. The most important thing is to actually not rush through inserting, sort of pushing the gel in. What you want to do is you want to hold up the penis up and basically try and push the gel in very slowly. Once that is done, I would also try and recommend that you clamp the urethra gently, because that will sort of give you more time for it to work. And the more time you give for your patient, the more they'll be relaxed and the easier for you to proceed with the catheterization. If you find it difficult, or if you know the patient is difficult to catheterize, I would recommend using more than one instiller gel. If you ever face a difficult patient. Obviously, before doing any procedure, you would want to obtain consent from the patient. So it is very important to explain to them what the procedure involves, the potential risks, the potential that it might cause pain, and basically all these acute risks of catheterization. You would want to make sure that you roughly go through with the patient. So it will obviously cause a bit of bleeding, cause a bit of pain sometimes, forced passages depending on the anatomy of the patient and how difficult it is for you to insert it. There's always a chance of failure, urethral damage, paraphimosis, urological emergency, and there's always a sort of risk of infection really. So these are the sort of risks that you would want to go over with the patients. Now we do have different types of catheters again. So we do have the short-term catheters. These ones can remain in situ up for about 4 weeks. My advice is before you actually unwrap the catheter, have a read about on the back of the catheter sort of packaging, and it should tell you how long you can use each catheter for. Some of them are long-term catheters, which is most of the catheters in the hospital, I would say. These are made of silicone, so they can actually remain in place for about 12 weeks. Now, the sizes that you might come across are between 12 to 16 French. The bigger the number, the bigger the size. But you would really, when we're talking about 2-week catheters, you would not really want to go over 16 sometimes, because 16 would do the job and more really. We do have catheters that are called 3-way catheters, and now these catheters are sort of a bit wider than the normal 2-way catheter that you would see on a day-to-day basis. We usually reserve these catheters for hematuria, to allow continuous irrigation, and to do bladder washes, which I'll talk to you guys about later. This is how a 3-way catheter looks like. So it's essentially the same as the normal catheter, but it does have this extra channel here, right? So this is where the actual catheter drains all the urine in. This is where you would inflate your balloon. And this is the third channel where you would sort of use to do irrigation for the bladder for hematuria, or for you to do bladder washout. It comes in different sort of sizes as well. So the best thing to do is actually put the best ones I've found so far when I was practicing is a size 18 3-way catheter, which I found that it does the job pretty well. This is just another picture of how it looks like really. You will come across suprapubic catheters, and I have to admit, when I came across it the first time, I was quite intimidated because I thought it was sort of an invasive procedure that I have to do. But my advice is not to panic. It is actually easier than a urethral catheter to insert or to replace. But the most important thing is for you to never actually attempt to insert a new one yourself. You need a urologist for that. And if the suprapubic catheter is getting replaced for the first time, I would recommend calling a urologist because there might be some potential complications initially. So make sure that a urologist is informed, and you could observe them and see how they do it, so you can learn from them. This is how it actually looks like. So there, as the name suggests, it's just a suprapubic one. Instead of putting it through the urethra, you go through the suprapubic area here. So that's how it looks like on a real patient. This is what it is really. So it's essentially, you go through the abdomen, and then you go through the actual catheter is in the bladder itself. So it has nothing to do with urethra. So I just thought of showing you guys how it looks like really. You will come across a lot of antibiotic administration when you're doing urology. So our favorite antibiotics to use are gentamicin and ciprofloxacin. So knowing when to use prophylactic antibiotics really can be useful. So normally we would use it for patients who have had previous infections from catheterizations, or they are at a high risk of infection if they're immunosuppressed and whatnot. If you come across difficult patients when it comes to catheterization, and if they're at risk of endocarditis. And if you're not sure, always ask. So you would always, after inserting a catheter, you would always want to make sure that you measure the volume of the urine after you insert it. So what that means is, after you insert it, stay there for a while, see how much urine has actually been drained, especially when you're dealing with an acute urinary retention, and document that. The consultants need to know about this. It will sort of change the management based on how much the patient actually drains out. When you're inserting catheter, you would want to document how much volume, how much mLs have you put of sterile water have you put into the balloon, because it will help you. It will help you or the people who are actually about to take the catheter out, because some 3-week catheters need to be inflated with more than just 10 ml balloons. Sometimes you have to put 20, sometimes 25, sometimes 30. So everyone needs to know about how much you have actually put into the balloon before deflating it. You would also want to document the procedure itself, including that you've gained consent from the patient and findings, if anything, difficult catheterization and whatnot. And the most important thing really here is to replace the foreskin to the original position in males, and this is to avoid having a paraphimosis, which is a urological emergency. Never use a female catheter for a male patient. All the female catheters will have a big label in the middle that says female catheter for female use. Never ever force the catheter, because you would put the patient at risk of false passages and potentially having a more complicated procedure than just actually a normal catheter. Never inflate the balloon before urine is draining. I've had incidences where some of the patients have had their balloon inflated within the prostate area, and it caused a lot of pain for them. So just inflate the balloon whenever you see urine, because that means you're more or less in the bladder. Bladder washouts, right? So bladder washouts is one really fun procedure that I've come to learn. I've learned it from the nurses, and I've learned it from the consultant the first time I did it. And we do normally use that to remove clots from the bladder and to unblock a catheter, normally within patients who have had hematuria and whatnot. So the equipment that you would require is a 50 ml syringe, quite a big one, yes. You need the bladder irrigation fluid, which you can get from any surgical ward. And you need a large bowl for you to sort of put the catheter in. And I'll explain to you guys how to do a bladder washer in a bit. So you would want to make sure that the 3-way catheter is inserted initially. You would want to disconnect the irrigation fluid. You would want to measure the bladder volume using a bladder scan, whatnot. You'd want to place the end of the catheter in the bowl that I've just told you about. Wipe down the ports with an alcohol wipe. Try and squeeze the irrigation fluid into the irrigation port, which is the third channel of the catheter, using the syringe. And you need to take note of how much you put in and how much comes out, and what color and the presence of clots, really, because this will influence the management. If you feel like that the catheter is not freely draining urine, then what I would suggest is just try and gently pull back on the syringe, and do not keep putting more in if nothing comes out, because you would put the patient at risk of sort of being uncomfortable, and they will be in pain later on, especially if the catheter is not draining. If you come across any further trouble during that, contact your seniors or the urology team. And if you're not sure, speak to the nurses on the ward. They're actually quite good at this. The first time I remember doing it was when a nurse have actually shown me how to do it, and I've just sort of refined my skills when I've been on a ward run and I've had to do it in front of the consultant. So in doubt, if ever in doubt, just call for help, really. You would always want to have one of these bad boys with you on a ward round. You will pretty much almost always have to do, well, not you, but most of the time the consultant will have to do a DRE on the patients, and having the lubricant gel with you will be in handy, because honestly, I've had trouble sometimes finding it on some of the wards, especially if it's a medical ward. They don't know where they pull it, and it takes a bit of time. So if you have this in your pocket all the time, it will come in handy. So things that urology have sort of helped me gain is I've sort of been nicknamed the catheter ninja around my hospital by some of the medical registrars, some of the F2s, my colleagues, some of the F1s, because you would, at the end of your rotation, you would sort of learn to deal with difficult catheterization, and you would know how to use different types of catheters for different types of sort of patients. I did sort of get the confidence. I have more confidence in dealing with urological emergencies, which otherwise I wouldn't been able to before if it wasn't for urology. I've learned to be sort of more independent, being the only junior doctor on the team, and most importantly, I was able to sort of become a safer doctor, because if I was ever in doubt, I would always call for help, and that's what they expect you to do as an F1 or an F2, really. And it sort of made me a bit more organized, because obviously the consultants will depend on you a lot for sort of leading the ward rounds and knowing what your patients are in for, where your patients are. Now, lastly, I just wanted to sort of shine some light on the urological emergencies that are important to recognize and act upon, or escalate if you're not sure. Now, as I said, I was supposed to give this sort of talk with my consultant, but unfortunately he's not here. He had some sort of tips and tricks on how to deal with these emergencies, but it's good if you sort of could know what the urological emergencies are, and sort of try and recognize them and act upon them if you ever come across these presentations. So it includes acute urinary retention. It's always an emergency for you in urology. Hematuria, more or less, yes. Testicular torsion, epididymoarchitis, and scrotal pathologies. And a very important one is an obstructed infected kidney, as well as renal stones. It's very important for you to sort of recognize and try and manage if you're able to. Paraphimosis is very important for you to recognize. And not necessarily a urological emergency, but generally a surgical emergency would be a foreign gangrene. Unfortunately, I would have loved to talk to you guys about all these emergencies, but you need about at least a 2-hour sort of talk for you to sort of go through these conditions. And yeah, I think that's it. Hope that wasn't too quick for everyone, and I hope you have sort of learned something from me today. Yeah, one last thing that I wanted to say is, if you are doing urology, or if you're doing any specialty, really, there is a really important and sort of really good course that you can do for free, and it's called the National Education Catheter Program. If you just Google that, it's free for all. You can literally do it at your own pace, and it will get you a certificate at the end. And if you're looking for a career in surgery, if you're applying for core surgical training, it will help you with your applications, and you can get 3 points, really. we can take any questions now, if that's all right.
Great, thank you very much, Baraa. That was a really useful presentation. I'm just going to have a look here. Would anyone like to ask any questions? If you could pop them on the chat box, and I'll be happy to read them out to you, Baraa. Looks like you've covered all grounds, Baraa.
Well, that's good to hear. Hope everyone
Yeah,
has
there's no
enjoyed
questions
it.
at the moment. I think,
Yeah.
yeah, that's fine. So could we maybe move on to the next slide? If you guys happen to have any questions later on, feel free to send us an email and at the urology@mindthebleep.com email address targeted towards Baraa, and I'll be happy to send it across to him, and I'm sure he'll be happy to respond to those questions. Otherwise, we really appreciate your feedback. Obviously, this is the last session for the urology series, so we'd be grateful for any feedback so that we know how well we did and what sort of things we could have worked on and so on and so forth. So thank you all for joining us again today, and hope you have a good evening. Thanks again, Baraa. That was a really great presentation.
Thanks,
so
thanks for the chance. Thanks, Mind the Bleep. Thank you very much. Thanks, everyone.
Thank you.